All right, great presentation, thank you. We now are going to switch gears and talk about the healthcare and medical technology business with some great leaders from the field. We're going to hear perspectives about the importance of building data cultures and the talent pipeline, as well as the challenges that the healthcare field faces in the future. Our moderator is the Chief Data Officer of BigID, Peggy Tsai. Please welcome her. We're also joined by Jason Johnson, Chief Data and Analytics Officer at Dana-Farber Cancer Institute, in the middle there. Fani Pidimari is Head of Strategic Planning and Partnerships, Enterprise Data and AI Solutions Group, Healthcare Services Corporation. Welcome. Shahidul Manan is Chief Data Officer of Bon Secours Mercy Health. Please welcome Shahidul. And Yazin Krishnaraj is Head of Decision Intelligence at the U.S. Pharmaceutical for McKinsey. Please welcome them all. Peggy, over to you.
Thank you so much. And it's really a pleasure to be here today at today's event, and to like to thank in advance my panelists and who I looked up to in the data industry as my peers as well. So really looking forward to this discussion. And some of the reasons why I crafted this title was to really deep dive into the healthcare industry. And this morning we talked about certainly the evolving role of the Chief Data and Analytics Officer, and certainly the partnerships they have with privacy and security. But let's spend a little bit more time in seeing how specifically in healthcare this role has evolved, and sort of the same themes around digital transformation, change management, data culture, data literacy. We're going to be talking, exploring all those topics in the next hour. But before we continue, I'd love for panelists to dig a little bit deeper and share with you their backgrounds. I know a lot of you have come from different backgrounds before they settled into their current roles, so love for them to share with that today. So we'll start with Yarni.
Thank you, Peggy. Thank you all for the opportunity. I'm Yarni Krishnaraj. As Peggy mentioned, I head up the decision intelligence for U.S. Pharmaceutical for McKinsey. For people who may not know about McKinsey, we are pharmaceutical distribution company. 1/3 of U.S. market share for pharmaceutical distribution. We do it in fact, we have done millions of COVID vaccination distribution. So it's really a very impactful company which supports the healthcare system throughout the U.S. So I'm really proud to be part of the company in the first place. Peggy was asking me about, and a couple of my panelists were also asking about the title, right? Are you really a CDO, or why is it called Head of Decision Intelligence, right? When you look into my roles and responsibility, I'm the Chief Data and Analytical Officer for my U.S. Pharmaceutical Solutions. But by choice, we made the title as a Head of Decision Intelligence because the way that me and my boss wanted to really create this team was to really make an impact in the business in how they are making a decision. It is not about just technology or data. End of the day, the insights that are being created and how it's going to impact the business, that's what matters the most. So we really wanted to make sure that that is the mission of my team, is to really have that decision science, make impact in the decision science. So that's why we went with the title. So I just thought I'll share the reason why it's titled differently. But yeah, that's and the other thing Peggy asked me about is I actually come from a financial services background. I worked for a bank for several years before moving to healthcare. End of the day, the domains, the data domains domain is different, but technology stack, the challenges, everything remains the same. So from a transition perspective, it's been a great journey because I've been in the healthcare industry only for the last year and a half, but I'm happy to be here to share my experience.
Thank you, Yarni. And I know I did ask you to cover a lot of things, so certainly the decision to call it decision intelligence, I think it makes it a more business-enabled term, and I think that's very action-oriented, and I think we've seen that in the past with data governance. We called it business enablement and other terminology, so I love how McKinsey really leaned into that business effort. So continuing on introductions, Jason?
Hi. It's a privilege to be here. Thanks to Peggy and David and the others who put this together. My training and background is in biophysics and computational biology, so it took a little bit of a path to get to where I am. I spent most of my career in biotech and pharma, and the last decade or so in healthcare, and the last 7 years at Dana-Farber Cancer Center in Boston as the Chief Data and Analytics Officer. The role was created when I joined, and we sort of invented it together to address a variety of needs. Dana-Farber is an academic medical center, which is half research and half clinical care, so it has this sort of unique balance. And so my role is also half research-facing and half clinical and operational facing. And that means I provide scientific services like bioinformatics and AI to researchers, and we help with, we serve as an honest broker to help them access clinical data when it's appropriate and provide infrastructure in the cloud and other kinds of services that are more like IT to researchers. And on the operational side, we built data warehousing and lake solutions and business intelligence program and reporting and analytics there, and we're moving into AI and other things across the board.
And Jason, you're the first Chief Data and Analytics Officer.
I think so.
in your role. So we'll be talking more in depth about that progression as well. Continuing on, Fanny.
Good afternoon. Very nice to be here. Great to hear the stories from my fellow panelists. My name is Peggy. I am the head of strategic planning and partnerships with HCSC. Trick question, how many of you know what HCSC is? Oh, there you go.
There's some
I'm
names.
surprised. I didn't know them before. But HCSC, as they call themselves as, Healthcare Service Corporation, is a payer industry. We are a payer across 5 different states. We operate Blue Cross Blue Shield across Texas, Illinois, New Mexico, Montana, and Oklahoma. This is my second rodeo within the healthcare space, but most of my time in the last year or so, or I'd say more, I've been spending time to prove the point that CDAOs don't belong to one industry. They go across industries. The business problems are similar. To Yarni's point, it's about delivering value and products. My role specifically is focused around strategic planning, AKA enterprise data and analytics strategy, really looking at the growth lens. As we all know, there's the defensive and offensive side. HCSC has been significantly focused on driving growth through data and analytics and AI and innovation. And the second half of my role is through strategic partnerships, really using the strategic partners outside, like the academic research institutions, really established partners with universities like Northeastern. We have an active engagement with Northwestern University, University of Chicago, University of Texas, Dallas, University of North Texas, a bunch of research kind of partnerships, along with partnerships with incubation partners, startups, really looking at what's the groundbreaking innovation that they're doing within the industry, within the healthcare payer industry, and how can we jump on board the wagon wheel to really take the organization towards the growth pattern. I've been a chief data officer, chief analytics officer in the past, more delivery-centric focused, but this is a slight pivot from what we all call a traditional chief data officer. This is mainly under the chief strategy officer for the organization, corporate strategy being the driver, growth strategies as one of the focus areas. So definitely excited for the opportunity. I've been with them about 8-9 months now, so fairly new there, but spending most of my time learning about health industry, healthcare industry, which is massive, as we all can relate to. And there's so many breakdowns in this table right now. So I'm definitely looking forward to learning from this panel a lot more.
Thank you. Last but not least.
Yeah, great to hear about my peer panelists along the same line. Shahidul Manan. I'm the Chief Data Officer with Bonsecours Mercy Health. We are a hospital system of 70 hospitals, about 80,000 employees, and 20 million patient lives across 7 states and Ireland, mostly mid-Atlantic, Midwest area. So probably haven't heard the name in this zone as much. And as for my role, I've been in the past in similar roles in financial, fintech for a long time, then went for high tech, Dell EMC, and software companies, and then moved to healthcare in last decade. And it's been a tremendous journey. I think healthcare is scratching the surface in many ways, but sitting on a gold mine of data, a lot of innovation happening and ways to come and moving towards AI. And as Jason mentioned, tons happening in the academic side of things to move the needle. And as for my role, I think the role is also evolving. It's interesting to hear my peers. So I have almost 3 hats in many ways. The biggest one, of course, is building and overseeing and managing the enterprise data assets, data governance, and overarching data to analytics to AI lifecycle management at enterprise level with enterprise KPIs for all our hospitals, all our overall business, and we have 6 subsidiaries that we also support and build data assets for. And then focus on the enterprise level reporting and KPI and analytics strength. Small data science team, more on innovation. So going to that, my second hat is more on innovation, tinkering with the new sets of technologies, emerging technologies. It's almost evolving into helping moving the digitization and from strategy to execution. And all of us in the room, I think, knows that in the last decade, digitization has been predominantly driven by data, AI, cloud, along with all the other great things happening with customer and other management or front-facing things. But these are the core drivers in the back. So this would be probably my third, where the data-driven digitization has been a big part of my portfolio, be it moving first to the cloud, overcoming the healthcare privacy and security challenges, as well as moving the needle in innovation with data, with AI capabilities. And then the third hat I have is now on the provider front to more focus on monetization and productization. Those who are in healthcare are well aware. I think, unfortunately, 53% of the providers are in the red today. And that's why a big part of all the innovation, all the digitization we are doing is not only to build new capabilities to serve and be better, but also how can we be self-sustainable and be financially viable. So a lot of value extraction through monetization, and that's a big part. I partner with both private and public companies and other peer provider groups to build and innovate new products that we take to the market. We partner with small to Microsoft-like big giant technology companies for innovation and commercialization to some extent. Of course, we can go over more how we do that innovation, making sure we have the absolute privacy and HIPAA regulations well covered, and managing our custodian relationship, our custodian responsibility as well. But that's certainly exciting and innovation slash productization part that we are carrying on our portfolio. More to come, I'm sure. Thank you, Peggy.
Thank you. And as you could probably hear, there's a lot of different topics and rabbit holes that we could certainly go into. But I think the first topic I want to cover more around the data and analytics is what is the business use case and drivers in your organization, and how did you position business, the data side to it? So let me just start first with Yarni. I mean, your role, relatively new to the pharmaceutical industry. How did you take some of the learnings from the financial services industry, which is also a very regulated industry, and what surprised you, and what type of frameworks did you take starting your role as head of decision intelligence?
Again, as I said, like between two industries, there's a lot of commonalities, and obviously the commonality is like obviously some of the data domains, right? Like if you think about it, you still have customer, you still have product. So the framework of how you think about your product and customer are the same. But the nuances come based on your business processes, right? Like how do you treat a customer in a retail is very different from a B2B customer, right? Like, so some of those nuances are actually impact the kind of a technology you are choosing as well, right? Like that's one thing, like, commonality, and then how you treat a B2B customer versus a B2C customer, right? Like, so how you deploy a solution, that's a difference. The main framework that I brought in, like from the banking to here, is like really a data governance, right? Like, so as an industry, again, ours is more of a supply chain. So we have a lot of data. inevitably, somebody said earlier too, like, the amount of data we are collecting is like tremendous amount of data. And we have a lot of analytics going on within the firm. What we didn't have is like really a right data governance, which is becoming a little bit of a pain point for us when more and more regulations are kind of coming in from an AA perspective, data perspective, and obviously HIPAA and all of that. Not having the right governance framework it was a pain point. So whereas like in the banking, especially in the bank, like I actually headed up the risk. So it was all about regulations and risk and how you govern the data. So I was able to take that framework around the data governance and deploy it in the healthcare environment, which was definitely very helpful for the organization to move forward.
You said something very interesting to me earlier today, was that the data maturity score in your organization is high, but data governance maturity is low. How do you reconcile that? How can you have good data maturity but low data governance maturity?
Yeah, so that's a good question, right? Because like nowadays, like everybody thinks they are the data analyst, right? Like anybody who have Excel is a data analyst. They can do data, right? Like 10, 15 years ago, like data scientists and data analysts, like they are very, very specific roles. Now like that layer is kind of becoming thin because there are a lot of tools out there, no code tools that is available. So anybody who have access to data can do analysis, can come up with the decisions. Are they coming up with the right decision? That's a completely different, data literacy and all of that we need to address. But coming back to your question of data maturity, everybody, especially like when a big business like Mickelson, people in a particular business unit or segment, they really know what their data is. Somehow they're able to get to the data, like maybe going into the system, downloading the information or whatever, and then they are able to come up with the data insight, which is valuable for that core business. But taking a step back, how it impacts the company as such, outcome of the company, a lot of people don't think of it that way. So that's why when I say data maturity is there, because people in their siloed way, they understand their own data, they know how to use it. When you think of a data governance, it's a one layer up. How those data points connect to each other, how is it affecting the outcome of the business, and why we need to govern, that maturity was like really lacking, right? And that's what we are trying to bridge that gap. There's a huge gap, and we are trying to bridge that.
Very interesting. And so Jason, coming to you, certainly you shared some interesting journeys as the first CDAO. And can you talk more about some of the business use cases and how you evolved that role within your company?
Sure. So to some extent, I think I had no healthcare experience coming in, and that helped because I could be curious and not bring any particular agenda. And it's such a heterogeneous and proud environment. So I think the strategy of kind of going to people, how does it work? What are you trying to learn? What data do you wish you had? Do you know where it is? What do you that kind of attitude was how I started. And then over time, you can start to layer in systems and platforms and approaches as you see patterns across the enterprise. But so one of the first groups that I interacted with is now one of the more successful data users, but that journey took years. And so it starts with, what data do you wish you could see? And what are you trying to do? As a business unit in a clinical area, what are you trying to do, and what data do you want? And then we tried to figure out where to get the data from. And that was all over the place, and it wasn't systematized, and there weren't definitions for some of the terms. And so we had to build out parts of the new warehouse to accommodate that. And then there was a phase of pressure testing the data. That doesn't make sense. That term can't be right because that doesn't make sense. And redefining, reinterpreting, putting definitions and assumptions into the data so that they did trust it. And then when they trusted it, then they could look at it and find this is everybody's data journey. But I think healthcare in particular hasn't gone through this before, or much of it hasn't. So these stories are sort of unique, and the people haven't done that, so they could see patterns. Why does it go up, and why is this going up? Why is that going down? Why is there a hole in the data? look at summer versus winter patterns and weekends versus weekdays, and they could start to ask questions, and we could start to make forecasts for them. And now, fast forward 3 more years, they are using models every day for staffing, for ordering supplies, for figuring out patient care, for everything, but they started from really nothing, except a curious attitude and an interest in having data. But that's also not uniform, that someone would be interested in having someone come in and sort of talk to them about data and help them over time. So that kind of story, I think, is it has a horizon of years to go through for a unique team like that, but it's sort of the pattern across my institute.
So as a sorry, go ahead.
No, one of the biggest challenge I think in healthcare is like, the seasonality changes, right? Like especially when you are talking about the models, right? Models you put together when there's a COVID and pre-COVID and after COVID, like it's, the same models will fail, like because the data is so different before COVID, during COVID and after COVID. So there are a set of data users who are able to interpret it, the models as it is, but the data experts are the ones who are able to actually say, what, there is a model drift and we have to be doing this. Don't interpret a model output as it is, right?
If it was the beginning of COVID, it's totally different than the end of COVID.
End of COVID, right?
In terms of utilization of certain services. Yeah, so we had that conversation recently about models trained in what period of COVID was it trained in, because how you use an ICU is completely different in different areas, for example.
Yeah, that's the biggest challenge, right? Like, talking about the data maturity or the literacy.
So Fanny, how about you? How do you utilize data and prioritize business use cases in your role?
Yeah, so this, again, as called out by both Yarni and Jason, there's tremendous amount of volume of data with different flavors of data coming in within the healthcare space. And it's also one of the most volatile. We talked about seasonality, but there's so many other factors really contributing to the complexity of data. And the underlying foundation or the challenge or lack of is more the quality challenges. The data quality is always questionable depending on whether we're looking at engaging with provider kind of data or looking at some sort of, say, pharmacy related data. There's always variances, there's always changes that come in. But if you look at the larger spectrum of us as healthcare payers, we look at a triangle of the combination of a provider who's one of our service providers, physicians, healthcare providers, the hospital networks, and so on. The other side is our members who are subscribed to our insurance service or their family members or the other areas. And we try to bring these two together with, until now, it has been much more behind the scene, right? Nobody really comes to health insurance providers unless they're like, hey, why is my bill so high, right? It's mostly during the claims processing. But there is a shift, or there's a mindset shift that is happening within the healthcare payer space. And coming in new from a non-healthcare background, I could relate it very well, where a member is being looked at as a consumer or a customer, which in a retail industry or a consumer-centric business, it's much more prevalent, where you try to be much more member-centric. You're trying to provide more proactive customer engagement by reaching out to them upfront. Good example is one of our members is heading out to a ER because they had some health condition. Earlier, we used to have an engagement touch point only when they had some concerns about the final bill that they receive after their treatment is done. It shifted now, where as soon as we get an alert message from the ER through data integration, where we get a real-time notification saying a particular member of yours is here with us, we immediately try to do the outreach to them saying, we hear that you are at the ER. Feel free to please consider us to be your close partners here. These are your benefits. If you have any questions about your benefits, let us know. And we'll make it as smooth of a transition for you from an ER to a care management like a hospital or post-care at-home recovery kind of service. So there's like the entire journey of the member is being looked at rather than one-off piecemeal kind of approaches. That's one area we're paying significant attention to. And the transition from being more behind the scenes to more being proactive is being looked at as one of the priorities. I mean, one, of course, however monopolistic the health insurance industry is, there's a lot of competition for us coming from these preventative care kind of providers, right? Put a patch on this and you don't have to go to the doctor is what they market as. But again, keeping the business side of the equation aside, but being more humanistic, being more human-centric is one of the motivations for us. Innovation, of course, stays continuously as one of the priorities. We definitely want to look at every aspect of innovation, and one of my responsibilities as partnership development person is to really look at somebody who's not coming back with a solution that's already been tapped into, something that's never touched upon. It could be member experience, it could be claims processing, it could be risk mitigation, risk adjustment, or fraud, waste, and abuse. There's a significant amount of fraud that happens within healthcare industry, within healthcare payer more so. How do we really mitigate that upfront so that there's minimum amount of fraud? We also do significant support for our sales and account management enablement because, of course, we are a non-profit, but we still have to run by numbers. So there's an opportunity for us to be much more predictive in terms of however volatile the market could be. We can't predict maybe another pandemic, but we know that based on a particular scenario or based on the pattern that we know, we could actually be much more prepared upfront in terms of sales, more from a corporate standpoint. We do a lot of corporate insurance, like AT&T, Boeing being one of our big customers. We try to be their healthcare providers, so we try to estimate costs for them upfront so that they as companies are prepared for what's coming up. But yeah, there's almost a 360-degree amount of value being generated using data and analytics, and more opportunities are being digged through on a daily basis.
So you said the word innovation, and I think that's not always associated with healthcare, but certainly a lot of the new technology changes. So maybe, Shahudal, you want to maybe talk about that? Because you also mentioned that in your intro. How have you used data or plan to use data and the new technologies in building and innovation in this area?
Sure, thank you. I think this is the question where we get to talk about Gen AI.
Sure.
But jokes aside, I think starting a little bit with the context, on the provider side, our world on digitization and data and AI and innovation is geared by the newer kind of paradigm of value-based care. And those of you who are not too familiar on value-based care, we have three key components that we look at. One is cost reduction, of course, and becoming a more efficient enterprise healthcare system. Second is patient outcome. How can we guarantee or ensure better outcome or improve patient outcome? And third, which is very common in others, is patient engagement. So with these three, our goal is reduce the cost and maximize the outcome and patient experience. So I'll go over a few use cases and then how we are looking at various innovation opportunities on that. So on the first one, cost optimization, we obviously are looking at our operational efficiency gains. And a big use case you may have heard, we look at hospital stays, predicting hospital stays and optimizing. One night spent longer after a surgery is not only can be painful for a patient, but also is costly for the insurance, for our hospital, our provider system. So if we just can optimize that, it does translate into tens of millions of dollars in terms of our efficiency and actually it also adds to the better patient outcome because patient can then manage or lesser exposure to the risk and infections in the hospital. And then we also look at like readmission prediction for COPD patients along the same lines, that if we can prevent the readmission by taking proactive calls, making proactive calls to the patients who's been released earlier and have the physician or the nurses take care of that over phone call or a video conference, that not only reduces the cost, but also takes away the pain of the patient coming back and spending a few more nights at the hospital. So those are very much prevalent, and data is the big driver. The algorithms that we build are going to be, of course, eventually automated and AI and built-in alert system. We look at optimization for scheduling. Scheduling is a big problem, as you may have experienced with your own doctor's appointments. But it's funny, on the provider end, because you can't find the right scheduling or you have to cancel the schedule at the last moment, we lose almost 30-40% of the slots that could have been utilized. So that's a revenue lost. So we try to optimize that, and there's a huge data science behind how we can manage the scheduling to better utilize and also reduce the wait time for our patients. Going to the patient engagement, that's a big one that we are now working on. Just as you do customer journey management on retail side or on e-commerce journey. And again, I think like my peers, I've been through various backgrounds, so I can relate to those along those lines. On the patient journey, we now are trying to make it seamless, that from the point of making your appointment to actually seeing the doctor, looking at the results, looking at the pharmaceutical various directives, and then post follow-ups, all can be done through a front door, a digital front door that is data-driven, and that can give you that custom experience, a very customized patient experience. And then a lot of innovation happening in the customized, personalized medicine. Now coming to the Gen AI, we are actually partnering with 2 companies on building out the Gen AI capabilities at a trial and then a little bit of product level. One is focused more on building a chatbot who can be, you can think of like WebMD type interactive, but more intelligent and more custom built for interaction. Like 3 o'clock in the midnight, if you have a stomach ache or some problem, you can go online and talk to the chatbot, who will be almost giving you a lot of good advice and tips, like a doctor or a nurse. But anything that would actually impact your outcome will immediately be passed on to a real doctor or to a real nurse behind the scene. But it is, again, becoming more efficient and also giving a great patient experience. And the last on this is we are also having a nurse triage that we are now optimizing through Gen AI and working with voice messages and video messages. So those of you who are not familiar, nurse triaging, we try to, again, triage the queue of patients and put them into the right services or right care path. And today, on an average, it takes us almost 15 to 25 minutes to send to the right caregiver once the nurses get the calls, or the hotline gets the calls and the nurses triage them. But through Gen AI and our other machine learning-driven, algorithm-driven decision making, we can reduce it to under 5 minutes. And again, tremendous value proposition. So it's an exciting time in healthcare innovation using AI, and all of these can happen only when we have high quality data supported by a great infrastructure.
I should say, whatever you called out, our goals are completely opposite to that, because
Oh, did you say the opposite?
Opposite?
the exact opposite, because they are providers and their the goals, the business goals are completely opposite. So the lens that we look at the cost, overall cost, and the lens that you look at the overall cost is conflicting, right?
In some ways.
In some ways, yeah.
But there are some synergy too. Like we try to reduce the cost because we don't get paid otherwise.
Right. The value-based care kind of
Right,
scenario.
yeah, exactly.
Yeah.
But you made a very good point, if I may. Just an interesting use case where provider and the payers kind of collide, which is, you may have heard, the medical coding issue in healthcare is big for billing and getting paid by the payers. So there are actually algorithms and AI word that happens. And in this word, the providers tries to minimize the errors so we can maximize our payments from the payers. And on the payer side, they try to catch more errors so they can deny the claims and pay less.
Yeah.
So it's an interesting evolution. I'm sure we'll do greater handshake in the future.
Absolutely.
I think that's why you two are sitting next to each other.
Together,
Maybe we
yes.
should have separated.
Like a duel.
Duel,
Sure.
right here on stage, yes. Yarni or Jason, I'd love to hear from you as well. What are your plans on Gen AI? Do you have an AI strategy? I think I asked you that, Yarni, and you said we have a data strategy, we have a business strategy. So I'd love to hear your thoughts on this topic as well.
Yeah, absolutely. Obviously, to me, it is important. Business strategy is more important, because AA or BA or data, they are all like providing solutions for the business. So the lens that we look at it is, what is the business strategy? What is the business priority for the year? What is their 3-year, 5-year, whatever the roadmap is? And our data and AI strategy kind of follows that, right? What are the problems that they need to be solving for in order for the business to be successful? And for those problems, hey, then these are the kind of AI solutions that we need. Our BA solutions that we need are, it's just a data that they need to derive insights. So that's the lens that we take. So I honestly don't like to call it as a separate data or AI strategy. It is more about business strategy. That's one thing. And then when it comes to LLM and AI, definitely we have made a lot of progress because innovation is the front and center for us. Even from a chatbot perspective, right? Like chat app, like we have our own chat app because privacy and legal is a key thing within our industry. So we really didn't want people to go out and do the, use the open chat app. So we created our own chat app, which is out there available for all of our businesses. And then we definitely are looking into multiple LLM use cases. Like for me, like one of the things, even from my team perspective, I'm looking at is bringing in the tools for development efficiencies. Like right now, like you really don't need developers sitting and writing a code anymore, right? Like, you can use LLM systems to generate the code and, do much faster development lifecycle than just doing a traditional coding, right? So those are the multiple things that we are looking at currently. Overall business productivity improvement and operational efficiencies through some of the LLM use cases, and also from a technology perspective, even technology team perspective, how can we be more efficient by adapting those LLM models?
And we are starting to explore all kinds of use cases, mostly around clinical care and not the provision of clinical care for AI. But if you look at the core data types that are relevant to oncology, it's images and genomics and text. And those are like the 3 very suitable targets for AI. And so for images, we're looking at, can we take scans, and this is in partnership with researchers who are looking at scans to see if they can detect pancreatic cancer early, because when it's typically detected, it's often too late to cure a patient. And if we can detect it early, then AI is very promising for something like that. We'll eventually save millions of lives for that kind of use case. So we're trying to bring that from research into clinical use. In terms of text, one of the problems with oncology in particular is that the data that you care about, one of the data types you care about the most is outcomes. Did someone respond to the treatment that you gave? And that tends to be buried in the text of the medical record. It's not in a lab result or some other structured field like A1C or something that you can tell if someone gets better or worse in diabetes or some other disease. But in oncology, it's sort of tucked into a narrative. And so LLMs are very suited to being able to pull out that information and help structure it. And on the other side, we're very excited about helping with the documentation burden for our physicians and other clinicians who are having to spend so much time with computers, and we want to have them have more time for their patients. And being able to hear the audio from a visit and record it into a summary of the note that they would approve is something we think is in the near future. We're not using it today except in pilots and testing, but that's going to happen very soon, and it'll be very important.
Yeah.
So just moving on to another topic, I always wanted to ask a group of panelists like this, what are the biggest hurdles or challenges or roadblocks? We always hear about success stories, right? So love to have the panelists talk or share anything they can share publicly in terms of lessons learned or roadblocks, or really some of the tougher things that it's not always shared or known about. And so love for you to share anything that you learned and you use that going forward in your career and in your job. Let's start with Shahidul.
Sure. So I think I'll start with one learning, and it was with one of the largest healthcare I was working with in New England area. And when I first laid out my strategy, the 3-year roadmap for data and digital path, it was the first going into cloud and using big data and going into tinkering real-time analytics and AI, which were all new to the very innovative system, obviously. And after getting the funding, and which everyone was excited about, it was almost taking 6 months just to go through the security humps to get approval to go into cloud, and which is totally understandable. We were working very closely. I always work in lockstep with chief privacy officer, chief security officer, legal counsel, and even in today. And one of my advice is always build a team around those when you are especially working in healthcare data. But in that scenario, it was going over 6 months, and we could say it could take a year because it was the first time. So everyone was hesitant and doing more and more. And then came COVID. And within 6 weeks, I built the infrastructure, built a real-time analytics, went live to show the COVID bed census because that was the need of the time. Within 6 weeks, going through all the security and everything. And that was not only highly appreciated, it got award in the system from the CEO, and it got highly reputed in the industry and got adopted by other areas. So the learning is twofold, actually, that one is work very closely with the team that I mentioned, and second is never let crisis go wasted.
That's a good
So I think that was a huge learning as well as success story towards that.
Yeah, one thing I could definitely say pretty confidently now that I've been in this industry is I always felt like the complexity is overrated in the industry, but then I definitely start to appreciate the complexity purely because there's so many nuances, so many different systems, so many different touch points, so many connections across the healthcare ecosystem. I mean, you're seeing 4 different flavors of healthcare on this space right now in this panel. But then imagine all of them trying to integrate together and really try to provide the best to the customer in the form of a member as an insurance company, or a patient as a provider, or as a research company, or a pharmacy company, or a patient as well on Jason's scenario. But then that definitely brings to me the attention of the complexity that the industry is going through. But what that led to is the humongous number of point solutions that got built across each of these problem areas. There's so many problem areas, and there are so many analytics players trying to provide one of these one-off point solutions across, saying, hey, we have access to this data from XYZ kind of data source, and we built this amazing product for you. And you being on the other side of the equation, you could have built the solution yourself, but you want to rely on this point solution because it's more build versus buy kind of analysis, which makes more sense. But then now we've reached to a point where as a company, as HCSC, we have, 1,000 different point solutions that we could tap into or rely into, and consider the complexity that comes through from the data standpoint across all of these systems coming through. Is harmonization, synchronization, governance aspect to all of these data sources, and that brings significant amount of complexity. I was doing a keynote last month in Miami with a room full of physicians, doctors, or practitioners converted into startups, right? They are like, hey, I used to be a practitioner, I was a doctor, now I have the startup, do you want to engage with us? And my question to them was, okay, I understand that you have the subject matter expertise, you understand the problem, you couldn't get the solution to the problem, so you come up with the startup, but then on the other side of the equation, we also have significant amount of shortage of physicians or nurse practitioners within the industry, so what's the balance here? And their response was, we got tired of waiting. We wanted somebody or someone to really think about the larger big picture of the healthcare ecosystem to really solve the problem. But I don't know, there's practicality kind of challenges involved in this. Is this like one big problem that somebody could solve, or it has to be like multiple point solutions out there? So that question is still in my mind. I'm still trying to figure my answer out. If somebody has any insights, let me know. But that's the biggest roadblock I would see, because eventually if you have to be successful as a data leader or building products that drive value for the organization, you have to have data across some decent set of sources that can be harmonized, that can be governed, that can be controlled from an end-to-end life cycle standpoint, from a data standpoint. So I'd see that as a roadblock.
Thank you, Fanny. Jason, from your perspective as well, I mean, certainly you had to teach your peers what a chief data analytics officer means and what they do. So I'm sure you faced some challenges in your role as well.
Sure. Yeah, I mean, I get the biggest challenge, the biggest roadblock, the biggest, is probably the difficulty of changing anything in the clinical workflow. This is it's such a tightly regulated, carefully watched, fraught with peril and harm, and also very stretched thin workers that are doing their best to get through the patients of the day. And so if you ask them to try something new or comment on something or test something, they don't have time. Even if it's designed to help them, they can't take the time away from it. So we see this acutely because we have a whole research enterprise of hundreds of labs that are publishing great models and ways of changing healthcare, and they sort of all pile up right at the edge of clinical practice. And this is an industry-wide problem. There are tens of thousands of papers now on AI and oncology published, and only a few methods that are actively used in clinical care daily, at least. And that's sort of a problem. The academic model rewards publication, and then the funding kind of runs out. And in order to test it, implement it in the real world, show the value, get the new workflows changed, it's a lot more expensive and takes different people and different kinds of project management, and so it doesn't tend to happen. So that's our biggest challenge. I'd say the only way that the success stories that we have are, in terms of changing something on a large scale, are when we have executive support across the board to stop a process and let something go in order to do something new. So the story that I think is the clearest in that regard is we had heterogeneous data definitions. When I started, people would make their own reports, and they would often be the same kind of data telling a different story. And so we had to define all of the terms and centralize at least the core clinical data. And so we sort of, no new reports, no new anything for a while, and everybody was bought in, and we put them in a room and talked about what is a patient, what's a visit, what's an infusion, does it have to be a drug that you're infusing, or is it just saline? What if it's a second opinion, does that count? What if it's a shared patient? What if it's, so even simple terms had to be argued about, standardized, and now, but that basically, with that buy-in from the whole organization to not have anything new for a while until we got those standardized, and to not make their own, to have those core terms be defined by my team in a warehouse that we manage, and we will then guarantee that if someone uses that word, it means the same thing as when you use that word, and the assumptions built in are going to be the same. And then you can add data types from your own area. But that was very successful, but it took this kind of institute level commitment. And so you look for opportunities to take them, or something like COVID, which then changes the whole risk environment completely. And you push everything through at that moment that you want to change, because you have this moment when people are willing to take risks, try things new, and you can get a ton done. But in a general operating model, it's risk balance does not favor innovation of that type. And our innovation tends to be, making something more efficient or making it safer, or there tends to be incremental innovation, which is still very important.
Thank you. And Yarni, before I let you answer that question, just a heads up, we're going to do Q&A. So please think of a question to ask our panelists, and hopefully we can have some mics available to give to the audience. So Yarni, I'm sure you have tons of stories, not just from your current role, but from your prior roles as well, in terms of challenges, roadblocks. Love to have you share your perspective.
Absolutely. I mean, I really concur with Jason, right? Even the simple definitions, especially when the organization is really huge, classic example you just mentioned, right? Like, definition of even patient, we are still debating. Let me put it that way, because when you say a patient, like, our finance department thinks somebody can be a patient only when they make their first payment, right? Like, and then whereas in a particular practice, the minute somebody calls the practice, then they are the patient, or, so, and then when we have practices across multiple states and different, between, different states, everybody have their own state rules and things like that. So based on their patient engagement, the definition of patient differs from each and every practice. So, it's just a classic example where, like, you have data, you have different things, but every workflow is very different. And standardizing and having a single repository or single definition is one of the biggest challenge, like every organization kind of faces, right? Like, I haven't come up with a solution for it yet. Data governance may be one way of solution for it, but bringing people on board to have that single voice or single definition has been a biggest challenge that we haven't solved for. The second thing is, like, really the value, especially as a chief data analytical officer, you are driving towards solving only X number of problems because you have only X number of resources. And how do we prioritize? Because there are people across the organization asking you to solve multiple problems, right? Like from COO to somebody sitting as an analyst in one of the organizations saying, like, hey, this is something that we want your help, we want you to solve for. How do you quantify and then really see, like, what is going to create a most biggest value or a return on investment, and like prioritization, as we have put in some framework around, like, what are going to be hard benefits, soft benefits, and, like, really make sure that we are prioritizing that way and commit that way. So we are trying to solve for that, but it's always like a balance between innovation versus value. Like, what can provide value now may not be the right thing to do for innovation, right? So what is your 80-20 rule to solve for? That's always the biggest challenge.
And that's certainly common across all industries, not just healthcare. So certainly see that as well, especially the defining what is a customer. I've certainly done a lot of those exercises as well in financial services. So love to hear from the audience as well. I know there's some of you, like Raj, you're also in pharmaceuticals. Love to hear others. Any questions for this esteemed panel?
Thank you. I'll take the first one if you don't mind.
Go ahead.
Well, this morning I had a question with knowledge graphs. If you were here in the morning, I would ask the same, but from the healthcare sector. The reason, in my university, I do research on semantic rules, of course, extracted from models, re-injected in models. And the question remains, in the different operations that we have represented today, to what extent do you, each of you, leverage such technology in complement to, of course, traditional AI?
So knowledge graphs, do any of you work with them?
I can say we are right now exploring most of what we were doing in natural language processing, knowledge graphs. We have chucked it for now and completely starting over with LLMs, and they're doing as well as, I mean, I can't speak for the institute or individual researchers, but in terms of the potential to replace the past with LLMs is incredible. What NLP, natural language processing, means as a field has just changed overnight. And we're seeing ability to do things with LLMs that are able to get pretty close to the old AI-based technologies, and they can extract knowledge graphs for you and things like that. So you tell me what the relationships are, or using this set. So there's a lot of applications around it, but in terms of applying it directly, mostly we've sort of parked those and are looking at what the language models can do, because it's so incredibly interesting and powerful, and can get close to what, in a lot of use cases, we have so much text, so it's very helpful.
Definitely, I have one comment to make too. As a highly regulated industry, there's always there's less of a niche to be the first, get the first mover's advantage, and we as healthcare payers too We are happy being the fast followers, even if that is an option. We don't mind being the second or the third, even in that line, as long as, because eventually there's a human life that gets touched upon across the space. So there's multiple warrants, multiple confirmations that are looked upon. But having said that, from my partnership standpoint, I mean, I definitely second Jason's comment about the shift on focus from the knowledge graphs to the LLMs has been pretty significant. We have an internal innovation lab that we look at where we try to test out each of the net new technological capabilities, and knowledge graphs have been one of our prominent testing areas as of last year. But with the Gen AI and LLM capabilities evolving, there's so much shift in mindset, and obviously there's immediate value being seen, immediate product offering that you could take, immediate insights that you could generate out of those that could be directly used for decision making, and hence I think there's the shift in mindset. But
one of the things we did yesterday, which is sort of relevant to this, is we're trying to make a knowledge management system for our analytics tools. What charts do we have? What dashboards? What graphs? What tools? What people? And we were going to go through the inventory and sort of do it manually. And now we use the AI to pull out the concepts.
Yeah.
What is our space? Tell us. List all the concepts and words and nouns. And then it's easy to clean them up. But generating that would have taken us last year a long time. And now we sort of have an inventory system. Make me my inventory based on this pile of stuff. And it does pretty close. I mean, whether it's comprehensive or not, but it's as good as, that kind of task, it does very, very well.
Great starting point. Another question?
Yeah, this is Tehran from Signal Sphere. What is the role that you see for third-party data to affect your internal operations? For instance, Yahin, if that's the right way to pronounce your name, when you look at provider data insights to affect post-launch marketing and sales effort, or Fani, using provider data in order to change the way that you engage or recruit patients based on what's happening inside. So the question is, data that you don't have the visibility to, third-party data, to help with this decision-making in your core product internally?
Yeah, I can shed some light on it. So that's a great question. And I think not so much from the marketing side or sales side, but as I was mentioning before, more from industry benchmarking and innovation for personalized medicine or risk stratification of patients, we do that. So one of the things we have first, I want to make sure everyone's comfortable that there is no compromise with privacy when it comes to healthcare data. So whenever we do that, we completely de-identify the data. We anonymize or de-identify. De-identify is sometimes we can re-identify internally only. We hold the key in case we need additional data or additional trace back to the patient. But then we have consortiums both at more platform and product level, as well as academic and other provider level, where we share our de-identified data to do, say, more population health related benchmarking. Or when we are building some AI capability to do risk stratification of behavioral health patients, for example, understanding the suicidal trends or risks, we help promote those type of innovation partnering with these third-party data, and or the more, I should say, bigger pot of data with many providers contributing to it in a de-identified form. And those type of partnership, I think, is a big silver line in a highly regulated industry like healthcare, because when we have this consortium where we can provide that comfort that we have managed the privacy, we have managed the HIPAA, and we have de-identified enough, and it's actually audited every year, we can work together to share our data for greater good. And then, of course, there is a monetization aspect to it. And to also enforce that concept, I would give an example that I think during COVID time, when we were first looking at the proving the efficacy of COVID side effects, Pfizer and other companies were struggling to get that industry data or to that provider data. And the only country that was able to share data was Israel, thanks to them. And then we could work out those side effects and understand those better. But now we are much better, again, taking little, I think, promotion from the crisis we had. We are much better in data sharing in an anonymized form or de-identified form. And continuously, the biotechs, the biopharmas, the vaccine groups, or even on the provider side, we have plenty to learn. We can share the data, use the third-party data in a de-identified form to understand our patients, understand various efficacies better. And in population health also, it's big. Understand even a population health risk and work towards a policy or work towards a larger initiative to enhance or improve the population health side. And I think there's more to come on that front.
Does anyone else want to answer that question?
Yeah, pretty prominent in terms of external data. Risk, of course, risk stratification is one of the common use cases. We want to make sure we are pretty aware of the overall risk that we are expecting from a particular population of members. But at the same time, there's other data sources from, say, wellness apps that come in these days, more devices, smart devices that actually capture a lot of health-specific information, and we try to consume that data to really drive and more create decision intelligence for us to come up with product offering that are much better for us, for our members.
Yeah.
Oh, go ahead.
No, in fact, like one of the things that when you asked about the difference between the financial services background and this one, like one thing that triggers me is like we didn't use too much of third-party data because it was all about operations, risk, and maybe in the marketing campaign, like a little bit of a third-party data that was used. Whereas like in our industry, like we use third-party data quite heavily. For example, demand sensing is a key thing for us, like being a supply chain, like, how can I sense the demand? Like, we don't want people to be queuing up for COVID-19 vaccine. Like, how do we make sure that we sense the demand ahead of time? So for that, like, we actually get a lot of market data. And then, like, similarly, drug shortage mitigation is one of the key thing for us, right? Like, imagine like we are serving the 1/3 of the country and we really don't want from your Tylenol to any critical medicine to be in a shortage. So how do we mitigate that way ahead of time, looking into weather data, not just from here, like, even news feeds, because when there are manufacturers, like if there's going to be an impact, if there is a weather impact this year, where the manufacturers, either it's in China, India, wherever, we know that's going to impact our drug, that's coming from that manufacturer. So how can we be even getting those news feeds, weather data, and all of that, so that we can predict and minimize our drug shortage is going to be key. So we do use a lot of external data for our predictions.
So thank you so much to my panel. Thank you to Northeastern University and David Matheson for allowing us to share our thoughts and perspectives. We'll be around for the next half hour for networking, and so looking forward to chatting with everyone more later today. And thank you again so much for participating.
Thank you.
Thank you.
Thank you so much, Peggy.